Alright, so we are now in the final section of this session. The goal here is to give a big picture overview of some of the ways in which addiction might be treated and to provide some of the evidence for the most common methods in current use. We will begin with a look at psychological interventions, then move into pharmacotherapy before we wrap up with an exploration of social interventions. Mainstay psychological interventions include things like cognitive behavioral therapy, CBT, and motivational interviewing or motivational enhancement therapy, MI and MET, in addition to aversive therapy and contingency management therapy. We saw earlier how contingency management therapy can be effectively used through the examples of HOPE Project and physicians being accountable to medical licensing boards, as well as promising cash or other rewards for clean urine drug tests. Aversive therapy actually suggests pairing a noxious stimulus with the drug. In my family, there's a story of a great aunt who was a smoker who gave her younger brother a cigar when he was like 5 and told him to inhale deeply several times. It made him so sick he never took up smoking. This is a perfect example of aversive therapy in action. CBT focuses on setting goals and making plans to accomplish them and thereby tries to activate the prefrontal cortex. And motivational enhancement therapy tries to develop discrepancy while acknowledging ambivalence to change. We'll take a closer look at CBT and motivational enhancement therapy on the next 2 slides. So, as stated, CBT focuses a lot of attention on setting goals. Goal-setting theory itself proposes that much of human behavior is regulated by conscious goal-making, especially as it relates to work-related tasks. One practical takeaway from this session today, then, is to look at 5 elements of SMART goals, which research shows can optimize performance. Findings show that the goals should, number 1, reflect the discrepancy between what the person has and what they want. Secondly, it should be specific. Third, it should be incremental, so progress can be monitored and feedback can be given. Fourth, it should be believably attainable. The person should think that they can actually reach and accomplish the goal. And lastly, number 5, the goal should be set high enough to keep the person motivated, to sustain motivation. Alternatively, motivational enhancement therapy is based on motivational interviewing. These techniques were developed with the treatment of addiction in mind. It has 5 core principles that are also very practical. They are, first, express empathy. Second, develop discrepancy. Third, avoid argumentation. Fourth, roll with resistance. And lastly, 5th, support self-efficacy. Now, as you'll find in basically every form of therapy, empathy is an indispensable element. Without it, the provider is doomed. You'll note that developing discrepancy was also a feature of the goal-setting theory seen in CBT. So there is a fair amount of overlap in between some of these theories. Self-efficacy came up in the World Health Organization as a protective factor against addictions, if you recall, and is also a cornerstone to many models of therapy. Now, it should be a no-brainer that argumentation is not likely to advance the therapy in a positive direction, but apparently it doesn't go without saying. Finally, one comment about rolling with resistance. This should be seen as an opposition to coercion. There is an openness to ambivalence, an acknowledgement that that is a natural part of the process of weighing the pros and cons of the addiction, or any bad habit for that matter, and a willingness to sit in ambivalence with the patient while the discrepancy continues to simmer and develop, if you will. If you need an example of some motivational therapy in action, I suggest one of the videos below, either Rocky or one by Kevin Hart, demonstrating what a personal trainer should and should not be doing. Now, what about the evidence for these types of therapy? Interestingly, a systematic review concluded that motivational interviewing performed by primary care physicians' nurses was effective in reducing harmful alcohol use. A Cochrane review a few years before that, in 2014, found that there is no difference in effectiveness between different types of interventions, and that brief interventions were not superior to treatment as usual. However, this was based on low-quality evidence. Switching gears now to look at pharmacotherapy for alcohol use disorders, the FDA has approved four different medications: acamprosate, disulfiram, oral naltrexone, and extended-release intramuscular naltrexone. A Cochrane review concluded that naltrexone appears safe and produces a moderate-sized effect for treatment of alcohol use disorder. Topiramate, while not FDA approved, has been shown effective in a meta-analysis, and its use is endorsed by the National Institute for Alcohol Abuse and Alcoholism. While it has less evidence, gabapentin also appears effective based on randomized controlled trials. As for the standard of care today, pharmacotherapies with a good evidence base to support their use have been developed for nicotine, alcohol, and opioid use disorders, but not for most other substances of abuse. Let's review the major medications that are recommended for these three substance disorders. We'll start with tobacco use. There are 4 medications that have good evidence to support their use. Varenicline appears to be the most effective at increasing the cessation rate by threefold. It acts as a partial agonist at the nicotinic receptor. There are concerns, however, about possible psychiatric and cardiovascular side effects. Bupropion also appears effective, nearly doubles the quit rate. It acts by increasing norepinephrine and dopamine. It is contraindicated in patients with a history of seizures, and because it is activating, it should be used cautiously with patients who have insomnia. Nortriptyline also appears effective, approximately as effective as bupropion. It appears to act by increasing norepinephrine and serotonin. However, caution should be used because it can cause dry mouth, urinary retention, and sedation, particularly in elderly patients. Nicotine replacement is also effective, similar quit rates to bupropion. Combination of the patch and a short-acting form, such as a lozenge, are even more effective, and this is a very well-tolerated form of therapy. Next off, we have alcohol use. There are also 4 primary medications for this that have good evidence. Naltrexone, first off, is an opioid antagonist. This has been shown to decrease heavy drinking days by approximately 17 to 25%. It is FDA approved. You should remember to monitor liver function tests, although it's not contraindicated unless the patients have severe cirrhosis or acute hepatitis. And it is recommended to use for approximately 3 to 6 months. Acamprosate is also FDA approved. It has been shown to increase abstinence rates by about 10%, which is to say You need to treat 10 patients for 6 months to prevent one relapse. And it appears well tolerated, however, it may cause diarrhea. Disulfiram is also FDA approved. However, this works by increasing the noxious metabolites of alcohol. And so most people don't like taking this. And it's not been shown to be effective in the outpatient setting. Topiramate is not FDA approved, but it is endorsed by the National Institute of Alcoholism and Alcohol Abuse. There are many randomized controlled trials that demonstrate its efficacy, including a systematic review, and it appears to act by modulating GABA and glutamate receptors. Finally, let's take a look at treatments for opioid use. There's two primary ones, although you might consider a third. First off is methadone, which acts as a full mu agonist at the opioid receptor. This may cause QT prolongation, so clinicians should be aware of that. It has been shown to be effective at reducing rates of HIV and hepatitis C transmission. It's also been shown to reduce rates of incarceration, and it increases survival, employment, and treatment retention. Buprenorphine is a partial mu agonist, and it has similar results as methadone. It is often combined with a mu antagonist called naloxone, and when it's combined with that, it's known by the name Suboxone. And the purpose of the naloxone is to block the effects if this substance is injected. But if it's taken orally, as recommended, then it simply passes unabsorbed through the GI. Treatment of addiction may entail multiple pathways and brain areas. More futuristic medicines may include ghrelin antagonists. Ghrelin, as you may recall, is a peptide hormone produced in the GI tract that is involved in mediating hunger. While these still need more research, animal studies suggest these may help curb the craving by reducing appetitive consumption behaviors. And if you think that this is just too strange, just consider how the weight loss medication Contrave is a combination of naltrexone and bupropion, which are approved for treatment of alcohol and tobacco use disorders, respectively. Blocking the high with vaccines is also an option, although this avenue has been pursued for many years now with less progress than hoped for. Targeting the executive suite, such as the prefrontal cortex, with the medication such as modafinil, may help people focus on the negative implications of drug abuse. It has a complicated mechanism of action, although it appears to be involved in dopamine signaling, and it has shown promise in cocaine addiction. Of course, there are many other pharmacotherapies for other types of drug addictions, but the intent here is just to provide a brief introduction of some of the possible ways that medications could be used. As for technological interventions, a Cochrane review concluded that text messaging using an expert system based on standard therapeutic interventions was effective at helping patients stop or reduce smoking at a 6-month follow-up. Mobile phone-based applications are growing in number and being marketed now as tools in the treatment of addiction. One example is Atacate. While the evidence does not support the use as of yet, or at least the evidence is limited, studies are underway and being planned as we speak, so we'll have to wait to see if these phone apps also prove to be effective in the treatment of addiction. Social interventions can be thought of as dividing into two types: downstream and upstream interventions. Downstream interventions are ones that involve increasing people's social connections after they have an addiction, whereas upstream social interventions represent more socio-political interventions that may have profound ramifications on the prevention of addictions in the first place. To begin with, downstream social interventions include things like Alcoholics Anonymous, AA, which is more broadly categorized as a type of mutual or self-help group. There are several types of mutual help groups. These include groups such as SMART, SOS, and AA. SMART is based on principles of cognitive behavioral therapy. SOS is an alternative to the faith-based orientation of AA. And AA introduced and is still based on the 12-step recovery model. Phoenix Multisport is yet another type that focuses on engaging members in outdoor and athletic activities as a means of promoting health and shifting the addictive energies, so to speak, into a more positive direction. A 1999 study found that there were accelerated benefits in the time frame of 1 to 3 years for an Alcoholics Anonymous group compared to other interventions, but there were no differences in benefits at a later time at 8 years. However, a 2009 Cochrane review concluded that the available studies did not demonstrate the effectiveness of AA or other 12-step programs compared to other interventions in reducing alcohol use or achieving abstinence. Finally, upstream social interventions again focus on policy that might help reduce the rates of substance use disorders and ideally help prevent them in the first place. While there are numerous possible policies to discuss, let's simply look at one which has gained a lot of attention lately. New York City has recently proposed something like a $13 tax on cigarettes. And in Oklahoma, there is discussion about increasing the cigarette tax. So, do these types of interventions work? Well, results from a 2011 systematic review show that the answer appears to be yes. The study concluded that most studies found that raising cigarette prices through increased taxes is a highly effective measure for reducing smoking among youth, young adults, and persons of low socioeconomic status. An additional study found that increased taxation also had the same dynamic effect on alcohol consumption behavior. It also suggested that increased taxation could be shown to decrease alcohol-related traffic events and other public health-related concerns. While these types of interventions may not seem to be the domain of psychiatrists, the number of people that may be benefited by upstream social interventions like these is significant, so it at least merits our attention. Well, that concludes today's session. I hope you have found this to be a helpful review of the normal reward pathway in the brain, as well as an engaging exploration of the historical, biological, psychological, and social aspects of substance use disorders, including mainstream and some slightly futuristic interventions for treating them. Thanks for listening. See you next time. Hopefully you were able to correctly identify these quiz questions as we were going through today's presentation, but let's just review. So the area of the brain most associated with willingness to work on difficult cognitive tasks is the anterior cingulate cortex. In neuroscience, the P3 is an EEG signal that reflects dopamine production and expectancy of rewards. This person, a key figure in the development of medical psychiatry, well known for distinguishing dementia praecox from manic depressive psychosis, who concluded in the late 1800s that chronic alcoholism resulted in cortical brain lesions and cognitive decline, was Emil Kraepelin. Oklahoma has the 5th highest rate in the United States of this substance used within the last month for people 12 and older, and that is tobacco. Reduction in this enzyme, responsible for metabolizing nicotine to cotinine, is correlated with decreased rates of nicotine dependence, and that is CYP2A6. This molecule has been described as the addiction switch in the pathogenesis of addiction. Did you get it? It's delta phosB. The establishment of craving has been associated with the accumulation of calcium permeable C, AMPA receptors in the nucleus accumbens. At the end of the Vietnam War, this percentage of soldiers reported being addicted to heroin. It's 20%. Though not approved by the FDA, use of this substance for treatment of alcohol use disorder is supported by results from a systematic review and endorsed by the National Institute for Alcohol Abuse and Alcoholism, and that is topiramate. And last, a 2016 Cochrane review entitled Mobile Phone-Based Interventions for Smoking Cessation concluded that the current evidence does support beneficial impact of mobile phone-based text messaging interventions for smoking cessation, at least at 6 months. If you're curious about where some of the information came from, here is a list of the references that were used in gathering the information that was presented.